Okay, so picture this. You're doing something totally mundane. Maybe reaching for the coffee on the top shelf, or, you're on mile 3 of a run you've done 1,000 times, and then zap.
I know that feeling.
That sharp nagging pain in your shoulder or knee. It won't quit. You ignore it for a week, then a month, and finally just surrender. You go to the doctor.
And after about 5 minutes, they say the magic words.
Let's try a steroid injection.
It is the classic medical moment, isn't it? It feels like the get-out-of-jail-free card for pain.
Totally. And for most of us, we don't even question it. We see the needle, we think relief, and we sign on the dotted line. But today, we're going to hit the pause button on that whole transaction.
Right.
We're taking a stack of research from Physio Hub, some really heavy-hitting reviews, and we're going to look at what's actually happening when that plunger goes down.
And just to, set the stakes here, we're not just asking, does it stop the hurt? Because, spoiler alert, the answer is usually yes. We're asking a much more uncomfortable question, which is, what is the biological price tag for that relief?
See, that's the part that got me reading through these notes.
Yeah.
We tend to assume if the pain is gone, the problem is fixed. But the sources we have today suggest there's this massive disconnect between feeling better and actually being better.
That distinction right there, that is the entire mission of this deep dive. These corticosteroid injections, they're incredibly good at shutting down the sensation of pain. They're the mute button.
The mute button, I like that.
But while the volume is down, there's a lot of biological chaos happening to your tendons and your cartilage that most patients, and frankly a lot of providers, tend to just gloss over.
Okay, so let's get into what's actually in the syringe. When I hear steroid, my brain immediately goes to, cheating in the Olympics, gym bros, that sort of thing.
Right.
But that's not what we're talking about here, is it? I'm assuming my grandmother getting a knee shot isn't going to suddenly bench press a Buick.
No, and please don't let her try. We have to draw a really clear line between anabolic steroids and corticosteroids.
Okay.
Anabolic steroids build muscle. They mimic testosterone. That's the gym bro stuff. What your doctor is injecting for pain is a corticosteroid. Think of it as a catastrophic anti-inflammatory.
Catastrophic. That's a strong word.
Well, I mean, in terms of power, it is maybe the most potent fire extinguisher we have in medicine.
A fire extinguisher for inflammation.
Exactly. It works by going into your cells and literally changing how they read your DNA to switch off all those inflammatory signals. It reduces swelling, it cuts down on the chemicals that tell your brain, ouch, and it just tells your immune system to take a nap.
Which, that sounds amazing. If my knee is on fire, I absolutely want the fire extinguisher. So where's the but? I feel a but coming.
Well, because inflammation isn't just bad, Inflammation is also the very first stage of healing. So when you nuke the inflammation, you're often nuking the body's repair process too. But to be fair to the drug, if you look at the reviews, the verdict is pretty clear. For short-term pain relief and getting your function back quickly, these shots are champions.
I think that's why they're so popular. We live in a fix-it-now culture. But let's look at the timeline, because this is where the magic trick starts to kind of fall apart. You call this the timeline trap.
Right. And this is based on a summary of randomized trials looking at knee osteoarthritis. So they tracked patients who got the shot versus those who didn't. Week 1, the steroid group feels incredible.
That's the honeymoon phase.
Totally. You walk out of the clinic thinking you're cured.
Right.
Weeks 3 and 4, you're still doing okay, but the effect is maybe starting to drift a little. But here's the data point that really matters.
Okay.
By weeks 6 to 8, the pain levels in the people who got the shot were statistically identical to the people who did nothing.
Wait, hold on. So the whole ride only lasts, a month or two?
In many cases, yeah. The injection buys you a window of relief. Maybe 4 to 6 weeks.
But it's not fixing anything.
It does absolutely nothing to change the underlying condition. If you had a worn-out knee joint or a torn rotator cuff before the shot, guess what? You still have it after the shot.
It's just a mask.
It's a very convincing mask. And that's where the danger comes in. It's like if your car engine is making a terrible grinding noise and you just cut the wire to the check engine light.
The noise stops, but you are not safe to drive across the country.
Definitely not. But we do this with our bodies all the time. We numb it, and then we go right back to playing tennis.
Which is the perfect pivot. From it wears off to it might actually be causing damage. This is the section on tendon health, and honestly, this is the part that every active listener needs to hear.
For sure. So this comes from a big systematic review that looked at what corticosteroids actually do to tendon cells.
And I saw the term catatonic in here. I know anabolic is building up, so catabolic has to be breaking down.
Precisely. Corticosteroids are catabolic to connective tissue. The review found that these drugs suppress the activity of tenocytes. Those are the little cells that maintain your tendons. Specifically, they reduce the production of collagen.
And collagen is the important stuff. It's the steel beams in the bridge, right?
It's the steel beams, so you're stopping the production of new beams, but it gets darker. The study also highlighted an increase in something called apoptosis.
I remember this from biology class. Programmed cell death.
Yes.
Yeah.
Cell suicide. The steroid basically triggers a pathway that tells the tendon cells to just die off.
Wow.
So you're not just failing to repair the bridge, you're actively,
Right.
you're telling the existing support crew to go home.
That seems so counterintuitive for a treatment. How fast does this happen? Is this after years of use?
That is what shocked me in the data. The cellular changes, the gene downregulation for collagen, the cell death markers, they can appear within 24 hours of a single injection.
One day.
One day. And those effects can last for 2 to 3 weeks. So think about that timeline again. You get the shot. Day 1, pain is gone, you feel great. Day 2, you decide to go for a run because you feel so good. But biologically, your tendon is actually weaker, it's softer, and it has fewer living cells than it did before you got that shot.
So you feel invincible, but you're actually made of glass.
That's the paradox. And that is why repeated injections are linked to tendon ruptures. We see it in high-load areas all the time. Rotator cuff, Achilles, patellar tendon.
Because you're loading a chemically weakened structure, but you've turned off the alarm system.
You've turned off the only thing that would warn you when it's about to snap.
It's terrifying.
Yeah.
Okay, but let me play devil's advocate. That's tendons. Tendons are like ropes, they're tricky.
Yeah.
Most people get these shots in their joints, knees, hips for arthritis. Surely cartilage is tougher.
You would hope so, but the news isn't great there either. It turns out steroids can be toxic to articular cartilage too.
Toxic how? Like, it melts it.
It just accelerates the breakdown. Studies show that repeated intra-articular injections, so shots right into the joint space, can actually speed up the progression of osteoarthritis.
Okay, hold on, I have to stop you. This is what confuses me. If the science says this rots your cartilage and this weakens your tendons, why is it still the standard of care? Why can I walk into any orthopedic office in the country and get one today?
That is the million-dollar question. And the answer is, well, it's complicated. Part of it is patient demand. When you're in pain, you don't care about collagen synthesis in 6 months.
You care about sleeping tonight.
Exactly. The doctor wants to help you sleep tonight. And this is a tool that works now.
So a short-term gain for, well, long-term degradation.
Yes. And also, for a long time, we didn't have these molecular level studies. We just knew patients felt better. But now that we know about the cartilage toxicity, the risk of actual bone damage, the guidelines are starting to shift. But medical inertia is a very real thing.
Old habits die hard.
They really do.
So just to pile on the bad news, we've talked about local damage. But does this stuff stay in the knee, or does it kind of go on a tour of the body?
Oh, it definitely goes on tour. This is the whole systemic risk factor. Even though you inject it locally, it gets absorbed into your bloodstream.
And what does that look like?
Well, there are cosmetic things like skin thinning or loss of pigment at the injection site, but the big one is adrenal suppression.
Yeah, explain that like I'm 5. What is adrenal suppression?
So your adrenal glands, they're like a little factory that makes your body's natural stress hormones like cortisol.
Right.
You need cortisol to wake up, to handle stress, to regulate inflammation. When you inject a massive dose of a synthetic steroid, your body goes, whoa, look at all this cortisol, I don't need to make any. And the factory just shuts down, it goes on vacation.
And when the drug wears off?
The factory's still closed, the workers are still at the beach, and suddenly your body has no way to manage stress or inflammation on its own. It leaves you really vulnerable.
I also saw a note in there about blood sugar.
Huge for diabetics. A single shot in the shoulder can spike blood glucose levels for days, sometimes to really dangerous levels. It's not just a local event.
It just highlights how casual we've become with these incredibly powerful drugs.
It does. And one of the papers noted something that really worries me. There are no clear universal lifetime limits. So you might see one doctor who gives you 3 shots, then you move, you see a new doctor, you get 3 more.
Nobody's keeping a running tally.
No one is really tracking the cumulative dose. It's like radiation exposure without the little badge.
Wow. Okay, I want to pivot to a really specific group of our listeners, the athletes. The weekend warriors. I know so many runners who treat a cortisone shot like it's just part of their gear.
Oh yeah, IT band hurts, get a shot, run the marathon.
Exactly.
This is where we need to put up a giant flashing warning sign. A 2023 review focused on athletes specifically, and they discuss a mechanism called angiogenesis.
Break that down. Angiogenesis.
Angio is blood vessel, genesis is creation. So angiogenesis is the body's process of building new blood vessels.
Okay.
Now think about a tendon. Tendons are white, muscle is red. Why?
Because muscle has blood and tendons don't. Not much, anyway.
Exactly. Tendons have a terrible blood supply. It's why they take forever to heal. They rely on angiogenesis to bring in nutrients and repair factors when they get injured.
And the steroid does what to that process?
It inhibits angiogenesis. It literally stops the body from building the supply roads it needs to go in and fix the pothole.
Wow. So you have a tissue that's already starving for blood, and you cut off the tiny supply it has left.
You got it. So if you're that marathon runner and you get a shot 2 weeks before the race to numb your Achilles tendon, you're stopping the blood flow, you're killing the tendon cells, and you're inhibiting collagen repair.
And then you go run 26 miles on it.
That sounds like a math equation that equals snap.
It really does.
And the review warns that these high-load tendons are particularly vulnerable.
There's also a competitive angle here, too. We mentioned doping. If I'm a serious amateur athlete, am I going to pop positive on a drug test for this?
You absolutely could. And this is often misunderstood. WADA, the World Anti-Doping Agency, prohibits these glucocorticoids in competition.
Meaning during the race or the game itself?
Right. But here's the catch. The washout period, so how long the drug stays in your system, can be really unpredictable.
Wrong.
So if you get a shot a few days before a competition, you might still test positive on game day. You aren't just risking your tendon, you're risking your eligibility.
So after all this, we've hammered on why these shots are dangerous. We've got cell death, bone rot, weak tendons. It sounds like the verdict should be never do this. But looking at the analysis, that's not actually the conclusion, is it?
No, and we have to be nuanced here. The goal isn't to fearmonger. The experts we read, they generally agree that steroid injections are not inherently evil. They're tools,
Okay.
but they're tools that need to be used strategically, not reflexively.
So help us figure out the strategy. What's a green light scenario? When would you look at this data and say, okay, a shot is a good idea here?
The green light is primarily about function. If the pain is so severe that you physically cannot move, you can't sleep, you can't walk, you can't put your shirt on, then the benefits of breaking that pain cycle, they probably outweigh the risks.
It's about quality of life.
It is, and specifically, if it's used to open a window for rehab. This is the bridge concept. Let's say you have a frozen shoulder. It hurts so much you can't do the physical therapy exercises. A steroid shot can numb it enough to let you actually do the work.
So the shot isn't the cure. The shot allows you to do the cure.
Precisely. The injection facilitates the rehab. It does not replace it. And, location matters. An injection into a shoulder is generally safer than one into a high-load tendon like the Achilles.
Okay, so what's the red light? When should we just run away?
Red light. If it's being used as a long-term maintenance strategy, if you're going back every 3 or 4 months just to keep going, you need to stop. You're just digging a hole.
And the athlete scenario we just talked about.
Huge red light. Never inject a high-load tendon in its early healing phase and then go train hard on it. That is playing Russian roulette with your connective tissue.
And the biggest one.
The biggest red light of all. Using the shot without any physical therapy.
That seems to be the golden rule here.
Yeah.
If you're not fixing the mechanics, the shot is just a delay tactic.
It's kicking the can down the road, but the can gets heavier and more explosive every single time you kick it.
So let's wrap this all up. For the person listening who might be holding a referral for one of these in their hand right now, how do we synthesize all this?
I'd say 3 things. 1, understand the timeline. Expect maybe 1 month of relief, not a permanent cure.
Okay.
2, respect the biology. Know that for those few weeks, your tissue is actually weaker, not stronger. So you have to act accordingly. Don't go run a marathon just because the pain is gone.
And the third thing.
Pain is information. This is really the core philosophy from Physio Hub. We treat pain like an enemy that has to be silenced immediately. But pain is your body's way of saying, hey, something is wrong here. Stop loading this.
So when we just mute it,
When we use a chemical to forcibly mute that signal, we're basically flying blind. We are turning off the smoke alarm while the fire is still burning in the kitchen.
that is a honking image to leave us with.
Yeah.
So before you take the shot, ask yourself if you're fixing the fire or just smashing the alarm.
Couldn't have said it better myself.
Thanks for diving in with us. We'll catch you on the next one.